Good morning, good afternoon, and good evening to all of you joining us from across the world. My name is Isidore Sieleunou, and I lead the primary healthcare financing agenda at the Global Financing Facility for Women, Children, and Adolescents, GFF at the World Bank. We are truly delighted to have such a large and diverse group with us today. It is an honor to welcome you to this exciting and informative webinar. This webinar series is co-organized by the GFF and the World Health Organization as part of our joint collaboration and learning program. The goal of this program is to support health system strengthening and improve health outcomes by promoting more sustainable and equitable health financing for primary healthcare services in low and middle income countries. Through this partnership, we facilitate platforms that bring together in Ministry of Health and Finance, subnational health representatives and partners to better understand country-specific needs and reforms. We also aim to highlight good practices in primary healthcare financing that can be adapted and applied in diverse contexts. As always, we are fortunate to be joined by global experts who will share proven strategies and innovation in PHC financing, as well as regional and country-led leaders who bring deep frontline experience with health system reforms. This webinar is a valuable opportunity to understand how countries are translating good practices into real-world implementation. It also serves as a platform for open exchange among decision makers, technical experts, and global partners to share not only challenges, but also practical solutions and tangible lessons on what is working and how. In essence, we are bringing together global insights, local action, and regional perspectives to foster shared learning and collaboration. Today, we turn our focus on Brazil, a country that has made bold and strategic choices to orient its health system around primary healthcare. Brazil's commitment to PHC has led to the implementation of several transformative reforms that have significantly improved health outcomes. By aligning PHC financing with a comprehensive model of care and leveraging key strategic levers, Brazil has moved decisively away from a selective approach toward a more integrated and equitable health system. We believe this experience offers rich lessons and inspiration for other low and middle income countries advancing toward a more sustainable pathway to universal health coverage. This session will offer an insider's perspective on Brazil's journey, enhance both equity and efficiency in PHC delivery. We will explore the country's achievements, the challenges that persist, and the broader implication for health system reforms globally. We will also benefit from cross-country reflection from Kenya and Pakistan, which will provide comparative insights and a broader regional perspective. Let me now introduce our esteemed speakers. We will begin with Adelson Guaraci-Jantsch, a family physician, researcher, and consultant committed to advancing PHC both in Brazil and internationally. Adelson leads education and international cooperation efforts at the Universidade Alberta do Sul, serves as technical advisor at the Healthcare Intelligence Hub within Rio de Janeiro's Health Department, and is an associate editor of BMC Primary Care. He also collaborates with several institutions, including Hospital Alemão Oswaldo Cruz, Fundacao, Geduri Vegas, and the Rio de Janeiro's Health Department. Following Adelson's presentation, we will hear from two distinguished panelists. Dr. Jacqueline Ashbuwe is a physician and public health consultant with experience in evaluating health programs, conducting primary research, and supporting evidence-informed decision-making. She also mentors researchers and practitioners with a strong focus on improving health service delivery at the PHC level. Our second guest will be Shabana Aider, who brings over 15 years of experience in health system strengthening, policy development, and sustainable finance. She's the country director for Think Well Global in Pakistan and has previously served as senior health advisor to the World Bank for the National Health Support Program. Shabana holds advanced degree in global health, public policy, and medicine. Moderating the panel today, we were supposed to have Fadi Jigme. Unfortunately, he has had some last-minute conflicting agenda. So Bruno Messen has accepted to step in to moderate the panel. Bruno is a well-known senior health financing advisor at WHO headquarters. Before joining WHO, Bruno spent 2 decades in academia and 6 years in humanitarian aid, a leading voice in knowledge management and collective learning. Bruno also founded several communities of practice focused on health financing and learning health systems. He holds a PhD in economics. And finally, last but not least, we will welcome Faraz Khalid, who will help synthesize today's key messages and takeaways. Faraz leads the collaborative learning and knowledge management workstream in the special program on PHC at WHO headquarters. He previously coordinated the UHC partnership in the Eastern Mediterranean region and has worked with WHO, UNICEF, AGB, and USAID. Faraz holds a PhD in global health policy and management and MPH and medical degree. With that, please join me in welcoming Adelson, who will now provide the framing on Brazil's experience. Thank you, and I look forward to a great discussion.
Thank you very much, Isidore. It's my pleasure to be here presenting my country, primary health care, and opening the debate for a big challenge for every country, and it's mostly for developing countries in the world. So let's talk about health financing as an enabler for primary health care orientation and the experience of Brazil. Here in the title, we have a lot of things already. Health financing, we have primary health care, and maybe many of you have primary care in your head, and also the experience of Brazil. So many things at once for just 30 minutes of presentation. I will cut many details on that. I won't present a broad story for you, but a few elements in the Brazilian history and primary healthcare history, and a few concepts, so it will help you to get a better understanding. Maybe for you listening now, you have one idea in mind, one picture in mind, similar to this one. That is one group of health professionals in front of one clinic in the community. They work together, providing care for the patients in the community. And also, maybe you have the concepts in mind for the 5 C's proposed by Barbara Starfield: the first contact, comprehensive care, continuity of care, coordination, and patient-centered care. So those are the well-known attributes of primary care. However, UNICEF and the World Health Organization, they present us a broader understanding of what taking care of people's health needs mean. That is the primary healthcare approach. And by the primary healthcare approach, they mean a whole society approach to health, aiming to maximize the level of distribution of health and well-being through 3 components. And those 3 components are, you can see here in the picture on the left: multi-sectoral policy and actions in blue, and empowered people and communities in red. And in yellow in the bottom, primary care and essential public health functions as the core of integrated health services. That part on the bottom is the primary care that many of you have in mind when we talk about primary care. But for the WHO and UNICEF, it's a bigger concept that is approaching the society. If you want to learn more about that, that is the document that presents primary healthcare approach and transforming vision into action. So from that vision, of the three components: multi-sectoral policy action, empower people in communities, and integrated health services. We went to achieve those goals for improved access and utilization of and quality of care, improve literacy and care seeking, improve determinants of health, and therefore improving universal health coverage, and also the SDGs. How to bridge this, how to move from that vision to action. That document, they proposed the 14 levers. And these 14 levers are the 4 core levers, that would be political commitment and leadership, governance and policy frameworks, funding and allocation of resources, and engagement of communities and other stakeholders. But also they present 10 operational levers. These operational levers are models of care, primary healthcare workforce, physical infrastructure, medicines and other health products to improve health, engagement with the private sector, purchasing and payment systems, digital technologies for health, systems for improving the quality of care, primary care oriented research, and monitoring and evaluation. Of course, we won't cover all these 14 levers. I recommend you to go to that document as a reference, but I will present how Brazil managed to pull some of those levers over the last years that made Brazil a history of success. So why Brazil? Because since 1990s, Brazil, the orientation of Brazilian policies were towards the primary healthcare approach presented in the last slides, and that contributed to reduce several health events, such as reducing infant mortality, chronic conditions, and reduced mortality and hospitalizations, avoidable hospitalizations due to primary care sensitive conditions. And also in the literature, you can find many different articles covering how the primary care strategy in Brazil touched many different outcomes and really impact mortality rates on cerebrovascular and heart diseases, infant and adult mortality, and other health events. So where should we start telling this story? So the starting point will be the same family health team we have here, the same group of health professionals working in the community. In 1994, was created a family health strategy that was a national policy designing a new model of provision of primary care in Brazil. That is the family health team you can see here on the left. And by family health team, I mean, we have now a new model of care, meaning what are the ingredients, how we combine those ingredients to deliver care to the community. So this is the family health team. What do they do? Or how is this family health team assembled? First, we have one physician, and this is very important. You have to have one physician on the team. We have nurses, one nurse per team, one nurse technician, and 4 to 6 community health workers. They take care of 4,000 people, or around 4,000 people living in the same catchment area. They work 40 hours per week and with a salary-based contract. What they do, so they provide integrated health services. They provide public health actions, vaccination, cancer screening, health surveillance, health promotion, disease prevention, but also patient-centered care, managing acute and chronic health conditions. And here you have one key ingredient for the family health strategy, that is the empanelment of patients. So the team is responsible for taking care of the people living in one catchment area. So in this picture, you have 4 different areas, therefore 4 different health teams. And one more ingredient, that is the decentralization. Who will be responsible for providing, for organizing, for contracting health workforce, organizing infrastructure, and managing daily work? The municipalities. They will be responsible for providing primary care to the population. So with this new model of care, we managed to move from a selective primary care, transitioning to a more comprehensive primary health care, from providing just a few health actions like growth monitoring or rehydration salts for diarrhea, birth control, immunization, to health promotion, preventive measures, management of acute and chronic conditions, rehabilitation, and palliative care. So what is the difference from selective to a more comprehensive primary care. Here you can see, for example, for maternal care and birth control for the mother, growth monitoring immunization for the little girl, oral reorientation salts for the boy when he got diarrhea, and tuberculosis treatment for the dad when he had tuberculosis. So instead of each person in the family having access to only a few services on a short list of health problems, each handled most of the time in separate rooms by different professionals, now we have the family health team and the family on the other side, and we have the empanelment. So each family is empaneled to one family health team. Family health team knows their families, and each family knows who their family health team is. We have the gatekeeper role. All health problems must enter the health system through the family health team in primary care. We have comprehensiveness. So they must handle health problems within the community, no matter what health issue is, and also coordination and continuity of care. The family health team is responsible for coordinating care over time with the patients, families, the caregivers, and also with secondary and tertiary care. With that, we reach the first break. Before I present how was primary healthcare orientation enabled in Brazil, I will invite Isidore and Bruno to the first break.
Thanks, Adelson. No, thanks. We stop here very quickly, and I would like maybe to engage already with Jacqueline and Shabana. So Jacqueline, you work in Kenya. Shabana, you will bring the perspective of Pakistan. I will come back to this question later on, but at this stage of the presentation, do you want to contrast the situation in Brazil with your situation in Kenya, Jacqueline, and then Shabana, if you can contrast or compare with Pakistan very quickly, and then we go back to Adelson. Jacqueline, please.
Thank you. Thank you, Bruno. Thank you, Adelson. So I'd like to draw a comparison, a similarity in the PHC reorientation that is taking place in Kenya, which is also focused primarily on service delivery reorganization from what has been historically a hospital-centric towards a more community-centered or person-centered approach towards service delivery. And I think that would be it for now. Thank you.
Okay, good. Shabana, one reflection from Pakistan.
Thanks, Bruno. So just quickly, while I will be talking much more in detail, I think to do quick points from Pakistan. One is the family health team in Brazil is equivalent to the basic health unit that we have in Pakistan. I think the membership with a doctor, a dispenser, a midwife, and also the community health workers attached, though the numbers are different, but I find similarity in that. The difference that I find between the Brazilian and the Pakistani model, as far as gatekeeping is concerned, we are gate unkept country. So like the FHTs, the family health teams gatekeep for specialized care and care in other echelons of higher facility care. In Pakistan, we don't have that. The referral pathways are there, but not implemented. So they can just bypass and go to higher levels of care for primary health care, which is, of course, a cost riser. And just to let you know, we are working in Pakistan on a case study on what actually defines primary health care and gatekeeping unkept countries like ours, because we need to determine the cost of primary health care in a secondary health facility or a tertiary healthcare facility, which hasn't been worked. So watch out for that work that we have, but I found that it's a difference. It's a contrast to what Brazil is doing right now. I'll stop here and have more reflections later on.
Thanks a lot, Shabana. Okay, very good and relevant reflections from both of you. So Adelson, we go on, and you explain a bit how Brazil managed to establish this family health system, family health team, and the PHC orientation.
Okay, thank you, Bruno. So yeah, how was primary healthcare orientation enabled in Brazil? So we will cover those three components that I explained for the primary healthcare approach. But yeah, so first I feel a little information about Brazil. We are federal presidential representative democratic republic. We're divided into 26 states and federal districts. And the smallest unit in Brazil is the municipality. We are a big country, fifth largest country in the world. We have a big population, 211 million people, and a ratio of 2.8 doctors per 1,000 people. And that is important for you to compare with your countries where you're coming from. And a lot of regional, racial, educational, gender, and wealth inequalities. In the right side, you can see a picture. So the darker regions are the wealthiest parts in the country. So the south and southeast part of the country is the wealthiest one compared to the north and northeast part. A lot of local inequalities as well. Pictures like this with wealth, very rich people living next to poor people in the neighborhood. We're still a very unequal country, despite all the efforts we've made to reduce inequalities. Okay, and then you can see the charts for the increase of life expectancy in Brazil and the decrease in child mortality. We now face more and more the burden of chronic conditions like cardiovascular disease and cancer, and still some infectious diseases, tuberculosis, and also deaths to violent causes. But let's go back here in time to the redemocratization that happened in 1985. That picture is from that moment. And what happened at that point in the late 80s, in the redemocratization, many things changed in the country. In 1988, we had a new constitution that was a turning point for the decentralization of decisions and also for the actions. So shared competencies between federal, state, and municipal governments, mandatory constitutional transfer between those three levels, and also the creation of decentralized systems based on the federative agreements for healthcare, that's the unified health system, for education, and also for social assistance. So we started in 1985 with the redemocratization, in 1988, new constitution, and then in 1990, the new unified health system. And the next year, in 1991, the first initiative for primary care was the Community Health Workers Initiative. And in 1994, the Family Health Strategy, at that point, the Family Health Program that I explained in the first part of my presentation was launched. After that, many policies and changes in the how it was organized and financed were implemented in 1998 and also in the 2000s. And here, 2010 to 2019 and 23, a few changes getting more and more complex following the increase in the coverage of the family health strategy in the country. So this is the conference that created the Unified Health System, the National Health Conference. Before that, we had the National Institute of Medical Care and Social Security, and the difference here was that to have access to that health system, you need to have be a formal worker. When we created the National Health System, the Sistema Único de Saúde, using a Bavarian model, now healthcare became a universal right guaranteed by the state. The system is now financed primarily through general taxation, and coverage is universal and free at the point of care. It's public funded and organized system, and with a strong emphasis in primary care, equity, decentralization, and also community participation. And that is a huge point that pulled all these four strategic levers. So we're talking now about the health system as a whole, not primary care, but you can see how these four levers were pulled together at that point in 1998. So healthcare is now a right of citizenship, not a job-related benefit. And all those four levers were pulled. So here we have the first component, the empowered people and communities. So we have health councils now with the unified health system at the municipal, state, and national levels, with the participation of the civil society. So 50% of the representatives must come from civil society for both the municipal and state and national conferences. We have also the councils of the states, the secretaries of health of the states, and also the secretaries of health of municipalities, universities, research institutes, and public health institutes. And also professional institutes like Brazilian Society of Family Medicine and Brazilian Society of Family and Community Nurses. They are all part and they are all invited for shared decision-making and the policies related to primary care after 1990s and 2000. So that process made really a huge impact on the decentralization and also for the shared decision-making of the policies for primary care. So how the Brazilian health system is financed, and here I'm talking about the health system, not primary care. So the revenue collection, as I said, through general taxation in the federal and state and municipal levels, all of them with this contribution, the public spending is legally mandated at each level. For municipalities must spend 15% of their budget, states must spend 12% of their budget, and the federal government must match the previous year amount adjusted by nominal GDP growth. There's a formula for the federal government. Pooling of funds. After that was created, the national fund, the state fund, and the municipal funds were created across all three levels of government. That made decentralization possible, promoting more equity. And also, finally, the purchase of services. So services are purchased predominantly public and based on historical budgets and population-based criteria. And more recently, in the last years, elements of performance-based payment are expanding. Expenditure on 5 specific health functions for primary care, or for the municipality, sorry. Primary care, a budget for secondary and tertiary care, for pharmaceuticals, for surveillance, or for management. So the expenditure is not aligned to one specific health condition or a specific disease, but for those 5 health functions as described here. Financial flow, you can see the chart here, starting from the left side, individuals, companies, and organizations, taxation and social contributions going through federal, state, and the municipal level. And here they're combined in the National Health Fund, the State Health Fund, and the Municipal Health Fund. That made possible for the flow of money to flow from the national to state and municipal funds for then purchase of services and health actions. Through the years, the trends in health expenditure in Brazil, so they increased from 6.7 to 9.5, starting in 1990 to 2018 as the share of the GDP. However, the government expenditure is only 41% compared to private expenditure, families and private, 58%. And here we have 27% in out-of-pocket expenditure and 29% voluntary private health insurance. And the family health strategy that I presented before in the first part, how is it financed? So in this document that Valerie shared with you, as long with a list of documents for you to learn more about the Brazilian health system and primary care, that document presents, so you can learn more about the floor for primary care that was created in 96 and implemented in 94. That established a fixed per capita component and a variable component linked to federal priorities. That is the fixed floor and the variable floor for primary care. So how this works. So the fixed funding floor is a per capita transfer that worked through 1998 to 2019. So it was a monthly automatic transfer from the national health funds to the municipal health funds based on the estimated population size. So depending on the size of the population of the municipality, you will get 24 or 28 reais per capita every year. So larger municipalities and those with a full local health system management receive a full amount. And then you have the variable component. That is an incentive per health team implemented in the city. This is an additional funding per each family health team registered and active. And for that family health team to be active, you must have one doctor, a nurse, and all the health workers contract and working in the place. So there's a value approximately between 11 and 14,000 reais per month per family health team. So here is a table with so the last number of the values for the fixed, and then in the first row, and then the variable components, the second to the bottom. You have like 23 to 28 reais per person every year. In the third column, you can see the numbers in dollars, in US dollars. And then for the family health team, you have like $3,000 per family health team per month. For a family health team, the Riverine family health team, as we call, it's a larger amount. For family health teams that work with homeless, also the specific amounts in the bottom. So with that, we have a fixed floor that is a stable source for the municipality, a stable source of funds for primary health care, and a robust strategy to tackle regional inequalities. In that way, anyone will have the same amount. And a variable floor, a strategic incentive for municipalities to embrace family health strategy. And that is a key component in the changes that happened in the new constitution in 1988. The federal government can incentivize, but it cannot decide if one municipality will embrace or not the family health strategy. So the variable floor is a way to incentivize municipalities to embrace and promote primary health care in their cities. With this picture here, a lot of numbers you can see. You won't be able to go through all of that, but this is a demonstration on how the fixed amount that is based on the size of the population varied from 5.6 billion reais to 6.8 billion reais. So it is increased because the population increased, but this is the fixed floor. And the variable floor, that one, that is the incentive for the municipalities to embrace primary care, quadruple from 2.6 billion to 10.4 billion over the years. So that demonstrates what you can see here, the success of a governance and policy framework, enabling funding and allocation of resources, and then improving this model of care and primary health care workforce and purchasing and payment systems. So those three operational levers were all pulled by this policy, and also the strategy of funding. Then in 2011, you have another one that is the Requalifica UBS for physical infrastructure, an incentive for physical infrastructure, for construction, renovation, and expansion. And here you can see the increase of coverage in the left side, the graph, from 1998 to 2020, from around 5% of coverage in 1998 to 60% of coverage of the Brazilian population. On the right side, you see the map and the percentage of the population covered in each one of those states. If you remember from the picture of the wealth inequality in the country, you can see that the poorest areas are those that embraced more the family health strategy. And here you have this graph showing one dark line in one light line. So the dark one is the fixed transfer from the fixed and the variable transfer from the federal government to municipalities. They increased over time, but also that made the resources invested in primary care from the municipality to increase even more. So the national strategy, and with the support of the Ministry of Health, the municipalities invested even more to increase and strengthen primary health care in the locals. Another strategy, this is quite important. You remember the family health team and how it was designed, one doctor, and this is compulsory. You must have one doctor in one family health team, one nurse, one nurse technician, 4 and 6 community health workers. So there's a nurse, a doctor, a nurse technician, and community health workers. In 2008, this NASF, the family health support teams, was created to support family health teams, to expand the scope of practice. So each one of those NASF teams cover now 5 to 9 family health teams, and they bring psychologists, social workers, pharmacists, nutritionists, physiotherapists, and other health professionals. For the fixed component, we still keep the same, transferring money according to the number of people living in that city. But for the variable component, NASU also brought a specific amount of money for the implementation of this strategy that increase also pull again the lever for the primary healthcare workforce, and again the lever for the purchase and payment system. Another strategy that was the more doctor program. We are now in the second wave of this strategy. It's initiated in 2013, and is a strategy to address shortage of physicians in underserved and remote areas, trying to solve provision and retention and training of doctors to work in primary care in remote and underserved areas. And also the PMAC, that was the first national performance-based payment for family health teams. So that also helped to pull the levers for a system for improving quality of care and also purchasing and payment systems. That's the first one, strategy for performance-based payment, and we are now in the third wave. The electronic health record. We have the Citizen Electronic Health Record that was produced and launched in 2013 by the Minister of Health. It is the official electronic health record for primary care. And with that one, we pull another lever that is the digital technologies for health. And the National Conference for Pharmaceuticals Assistance, listing a list of pharmaceuticals and medicines for primary care that must be available for in primary care in every city. With that, we pull another lever that is medicines and other health products. And finally, the Civil Society Organizations Regulatory Act. In the early 2000s, but gained traction after 2010 with the social organizations for health and public-private partnerships, contracts between municipalities and non-profit organizations for managing public facilities under performance-based contracts. We pull another two levers here, the engagement with the private sector and also purchasing and payment systems. And after 2019, we had a Previne Brazil that changed the way the fixed and the variable floor for primary care was organized and introduced a weighted capitation. Now we don't have more a fixed transfer for the total amount of people in the city, but a fixed transfer for the total amount of people subscribed to one family health team. So the amount of people in panel for one health team is the weighted capitation. And they introduced also a payment for performance and incentives for strategic actions. So finally, we reached the least domain here, the multi-sectorial policy and action. And that is a beautiful story that Brazil built in the last 20 years with the Bolsa Família program. Bolsa Família is a conditional cash transfer program with three components. The education, so the children between 6 and 17 must attend school regularly. For healthcare, families must ensure that children under 7 follow a national vaccination schedule and attend regular health checkups. And also nutrition, the participation in food and nutrition monitoring for children and pregnant women. With that program of the last 20 years, we managed to reach a few of the Sustainable Development Goals, as you can see in this diagram here. So we have the cash transfer, the health conditionalities, and educational conditionalities. Also, all of them combine reaching those specific strategic development goals, the Sustainable Development Goals. And with this article that was published 15 days ago, this is quite recent, high coverage of and high adequacy of the Bolsa Família program associated with a significant reduction in overall age standardized mortality rates. Conditions in primary health care. So primary health care in Brazil is truly in the driver's seat. I could say yes, because of all the expansion we made. but also no, because we need to work more on the integration with the first level of care and the higher levels. This is still an issue, particularly in terms of supplying actionable intelligence to inform planning across the whole network. And that'll be a call for pulling those two levers, the primary healthcare oriented research and monitoring and evaluation. Resource allocation and municipal management are a big challenge also. High unequal conditions across the country. Significant disparities exist in human resources, in hiring models and salaries. And also the distribution of physicians is highly uneven. We have one doctor per 3,000 people in small towns, but one per 230 people in larger cities. And finally, going back to the first slide, to the first picture you have in mind, the family health workers. So this family health team, they are doing the best they can to take care of their patients and working with performance indicators versus quality improvement. Setting goals and performance indicators, that is a trend now for primary health care, may not make their life easier when they're working, and maybe they may not improve efficiency as wanted. So with that, this is my last slide. Muito obrigado, and thank you very much.
Thanks a lot, Adelson. That was really brilliant. So, as you can imagine, we receive a lot of questions from the audience, some quite challenging questions, those which are more kind of clarification question. Maybe just one clarification question, then there will be other, Adelson, but community health workers in Brazil, they are from the community for the recruitment first, and are they salaried workers or are they volunteers?
Oh, that's a very good question, Bruno. They are all salaried workers. They are contracted by the municipality, okay, like the other health professionals. They must live in the community, in that catchment area where they work. They must live there. Most of them, more than 90%, are women. And that is, for me, in my opinion, my personal opinion, a good way to generate gender balance.
Okay, that's clear. That's really helpful, Adelson. I will come back to you with more questions later on, but I would like now to invite Shabana and Jacqueline to reflect. And I go back with the same question, and I will start this time with Shabana. Okay, now you can fully contrast the experience of Pakistan and Brazil. Shabana, can you quickly highlight a few points which you believe are really important in this comparison?
So just to start with, Brazil and Pakistan, both big populations. We're number 5 largest population. Pakistan is the 5th largest population in the world. Right now, I'm in Canada, and just to give you a size of the population, it's like 6 Canadas is equal to 1 Pakistan. So that's how big the country is. On the health delivery outlet, the tiered system, I think I've spoken, the BHUs, the basic health units, and the rural health centers provide primary health care, and they are equivalent to your family health teams, though with variations because their coverage is more. And then we have the secondary care hospitals and then the tertiary care hospitals. Similarly, like Brazil, we also have a huge community health worker network. So Brazil has one of the largest. I think the numbers are like 238,000, and we don't have such a large workforce. We have like approximately 80 to 90,000 lady health workers in the country, generally female, like Brazil. They're salaried and they're civil servants. So just to compare, so it's practically the same, but it all depends on what they're doing and how we're implementing it and the outcomes of the model. That's very different. I think Brazil and Pakistan both are decentralized countries. For us, we have 4 provinces and almost 170 districts. So public healthcare is generally taken up by the provinces after the National Finance Commission award, through which the provinces are funding. And like Brazil, through SUS, the healthcare is free. Pakistan's public service delivery is also free with minor charges for basic tests, etc. I think I also find similarities on community governance model from Brazil, because I saw one of Adelson's slides that talks about health councils. So in 2 of our provinces, we have 4 major provinces. In 2 of our provinces, we have this community governance models for primary health care, which are called primary care management committees and health councils in the 2 provinces. And they have a community membership and they have a facility membership, and it is to manage funds. It's like a variant of direct facility financing. So I find similarities there as well. And to be honest, I am not very privy and deep diving into the Brazilian model, but whatever I've read, the Brazilian model is also line item framework based. It's more dominant, which they call expenditure items there, and we call line items, because that is the dominant method for authorizing, releasing, and controlling public spending in Brazil. And that's also true in Pakistan. But just to deep dive a little bit on the health financing indicators, Pakistan roughly spends 3% of its GDP on health, while Brazil spends 9%. Per capita spending is $48 only. That includes private sector also and out of pocket. And Brazil's spending is approximately $920 or $930. A varied contrast. So we're spending pennies, to be honest, on health. And and out of pocket in Brazil is like 25 to 30%, while in Pakistan is almost 50%. So a lot of health is financed out of pocket. And we also have donor financing, which is especially true for polio, because we have polio in the world. Like we have few countries left with polio, and also around tuberculosis, malaria, HIV, AIDS. In just to compare and contrast on the 3 important pillars of health financing. So starting from domestic resource mobilization, Pakistan is tax funded generally from federal and provincial. As I said, there's a federal divisible pool, and through that, the monies or the taxes rate at the federal level are passed down after the devolution to the provinces. And this is called the National Finance Commission Award, and it has 4, basically, it's formula based. The formula is population, it's backwardness, it's inverse population density and revenue collection. So once the provinces receive the money, they decide on what they have to spend. So there is no set formula on from provinces flowing to districts, and districts are huge. Like you have a lot of fiscal decentralization in Brazil, straight away from federal, there are transfers mandated to the municipalities. We don't have that directly from federal to districts. That's not happening here. In health in the country, Pakistan, health in the federal level only looks after provincial coordination, medical education regulation, drug regulation, and implementation of international health regulations. Every activity, service delivery, policy, planning, overall services are left with the provinces. So to be honest, in general, a lot of decentralization has not happened, which should have happened from the provinces towards the districts in each of the provinces, but that's not happened. And we also have generally a low tax to GDP ratio, which it's like 12%. So that's why we don't fund the way, we have monies for health. On the pooling part, we have diverse pools. Sorry, Bruno, do you have a question?
No,
Yeah, sure.
we have to move on, Shabana. So you are very exhaustive. So still 1 minute maybe, but can you?
Yeah, sure. Just to talk you about the pooling of it, we have multiple pools. So a lot of fragmented pools. We have public sector pool, we have army pool, we have social security hospitals, we have railway hospitals and whatnot. And lastly, on the strategic purchasing element, we have through line items, there's very limited P for P. I think Brazil has started P for P, and there's a ceiling and there's a floor through its funding. So pay for performance funding. We don't have a lot of funding around pay for performance. Our strategic purchasing is generally, we have primary healthcare is financed through either, these line items or outsourcing, which I will, contrast later on. But that outsourcing is also through passive agreements and passive contracts. In Brazil, it's per capita transfer. We don't get per capita transfers for health. So I'll stop here and probably reflect more as you go on.
Thanks, Shabana. No, that's very exhaustive and it's really interesting. Jacqueline, and as for Kenya, so what kind of contrast would you draw between Brazil and Kenya?
Okay, so maybe I can start. Thank you, Bruno. Thank you, Shabana, and thank you, Adelson. So if you'll allow me, maybe I can go back to start with a bit of comparison. One, just to portray the governance structure within Kenya. We also do have a decentralized government system where we have the national government primarily responsible, the Ministry of Health primarily responsible for development of policy. And then we also have 47 county governments that's at the subnational level. And they are the ones who are actually the custodians of service delivery, including primary health care. So in terms of funding, there is pooling of funding at the national level. In terms of resource mobilization, let me call that resource mobilization and pooling happens at the national level and is channeled from the national treasury to the county revenue fund. And all the counties are responsible in terms of how they distribute and allocate the funding across the different to the health sector. So in terms of just drawing a comparison, as I had mentioned earlier, the primary healthcare reforms have really focused on integration of health, integrated health service delivery through reorientation from the previously hospital-oriented service delivery approach towards a more community-centered delivery service delivery model, whereby the healthcare workers are actually put together in multidisciplinary teams who are mobilized towards the community and bring the health service delivery closer to the community. The other thing that similar approach that Kenya has adopted for to support the primary healthcare orientation is ring fencing of funds, just like Brazil has done, whereby there's legislation of primary healthcare within the Primary Healthcare Act, and then also the adoption of a Facility Improvement Fund Act in different counties, whereby facilities are now have the provision to retain the revenues that they receive and reimbursements from the social health insurance in order to support operations within the primary healthcare facilities. One contrast I would like to draw between the Kenyan healthcare system and the Brazilian healthcare system is one of them is it's clear that Brazil is actually allocating a very significant portion of their GDP towards financing health. Kenya, I think, is allocating about half of what Brazil is allocating. And then additionally, it's quite impressive how Brazil has given a lot of focus in investing on human resources for health, who are really the backbone of providing healthcare services. I think we still struggle in that aspect in terms of adequacy of even the multidisciplinary teams that I mentioned, who are the service providers within the primary healthcare model. We still struggle with shortages within the health, shortages of health, human resources for health, in terms of just ensuring that all the services that are required within those smaller units at the community level are actually provided. And I think I'll stop there for now, just to allow room for further discussion. Thank you.
Thanks a lot. So well, I go back to you, Jacqueline, because you recently co-authored a political economy analysis of recent PHC-oriented reforms in your country. And I would like to, so Adelson presented his case by stressing the importance of the levers. So can you reflect on how the levers were used in Kenya? And then Adelson didn't develop the political economy aspect of such reforms. We can expect that there will be some supporters and some opponents. So if you take the case of Kenya, how do you reflect on these 2 points?
Thank you very much for bringing up the work that we did, led by Faraz Khalid. So I'll distinguish between the two, both the strategic and the operational levers that we observed played a huge role. So at the strategic level, political leadership, political commitment and leadership, synergizing with the governance and policy frameworks, and then also synergizing with the funding and resource allocation actually played a huge role when it comes to operationalizing the the primary healthcare oriented reforms, which now in our context we actually call the primary care networks. So at the operational level, the levers that we pulled on, that rather that the country has pulled on, include the models of care, where I talked about a shift from the initial hospital-oriented mode of service delivery towards more community-centered approach with what I call the multidisciplinary teams who deliver care at closer to the community. Additionally, mobilizing a bigger, or rather increasing the number of community, what we call community health promoters in our context, and ensuring that they're equipped to deliver services within their scope of what they're trained to do at the community level. So, and then though not homogeneously implemented, there is also digitization of care delivery, especially at the community level. So the other operational lever is actually what I'd mentioned before, the purchasing and payment of services, whereby there's a bigger focus on social health insurance. Like one of the counties we studied, which is Kisumu County, actually established a specific, can I call it organic fund, what they call the Marwa, which focuses on supporting the indigent families, indigent households who are really considered incapable or have very limited resources to access healthcare services. So the social health insurance, the county would pull funds and ensure that these they would pay for these households to be able to access basic health services. So as you said, political reorientation of primary healthcare definitely does draw tension, because it creates tensions, because it involves redistribution of resources and also centers of power in terms of decision making. And definitely there were tensions amongst the stakeholders who are involved in the reform process. So some of the biggest supporters included the political leaders, right from the national level and also at the county level, whereby within the political manifestos at the national and county level, primary healthcare was mainstreamed and explicitly supported as an accelerator for the achievement of universal health coverage. Additionally, there was, the political leadership actually now leveraged on governance frameworks, which I'd mentioned before, such as the ascension of the Primary Healthcare Act, and then also the adoption of the Facility Improvement Fund Act, which I had mentioned before. All of these were really key in terms of ring-fencing funds for the primary healthcare level, which had historically really been relegated to being a donor-funded domain. So really minimal support officially from the government kitty. So now all these worked together synergistically to ensure that the additional lever of funding and resource allocation now came into play. So now, but even when it comes to pulling the lever, particularly of the funding and resource allocation, there was definitely opposition from the finance teams, particularly at the county level, because they were not really for redistribution of the resources from curative and bringing more into the preventive and promotive health too, which is the core focus of primary healthcare. Additional opposition actually did come from at the organizational level stakeholders, whereby there was historically a vertical approach, a siloed approach towards service delivery. So with this new primary healthcare reorientation, which focuses on integration of healthcare services, there was resistance from the health management teams, and also resistance from the healthcare workers who, for their reasons, were not really for shifting the center of power from the hospital towards delivering care closer to the community. Another source of opposition actually was the rigid donor funding streams, which traditionally have been vertical, in terms of vertical programming. So when it comes to adapting this approach to funding towards an integrated approach, there was some resistance, but through conversations and through advocacy, the political leadership was able to win over the donors and just help them to line up and align their funding rather to support the primary healthcare approach. I think I can stop there for now. Thank you, Bruno.
Thanks, Jacqueline. So no, indeed, the situation in many African countries is quite different from the situation in Brazil. Brazil, you don't have to handle donors and aid actors as they have to do. And indeed, for PHC, it matters. Shabana, we will go soon to the questions coming from the audience because there are so many. But Shabana, you work in Pakistan, so you have heard this case from Brazil. What kind of take-home message you would pick for if you had some kind of highlight for Pakistan from the experience of Brazil?
Thanks, Bruno. I think there's a lot to learn from the Brazilian model. I think Brazil's PHC is an exemplar. I think when I read the Brazilian model very briefly, there are 4 things that stood out for me. One was, the political commitment to do these reforms, one. The second was 3 sustainable primary healthcare reforms, innovative financial reforms that they took. One was related to the constitutional guarantees of funding for health. The second was financial incentives to develop these family health teams. And lastly, what they're doing is the P4P for pay for performance on certain elements. And lastly, the integrated health service delivery. So keeping that in mind, what my cue for Pakistan would be, although we are spending very less, and I think it's time that we have more budgets for health, regardless, that all depends on the GDP that you're having. I think number one, I would like to start with having some constitutional guarantees for your spending, if not constitution, at least a commitment by each of the levels, like for the federal, for the provincial, towards primary healthcare. I think that's not there. So I would really like the government to take that up because for Brazil, I think it is for federal, it's 43%, for state, it's 26%, and for municipal, it's 31% contributions overall in health. We don't have that such kind of formula, so we should think about those. The second thing is greater fiscal decentralization. As I said earlier, we have the Federal National Finance Commission Awards. We also have a Provincial Finance Commission Award, but that's not implemented. What it means is that once we have the Provincial Finance Commission Award, we will be going to the districts under a certain formula, and that inequities created would be sorted out, at least more fiscal decentralization like Brazil. The other thing that I really liked is about the pay for performance. We have certain transfers that come from the federal government to the provincial government, but they are not performance based. So for example, if you want to, give an incentive on nutrition because we are the 3rd largest stunted country in the world, or on population planning, we could have some sort of a P4P by the federal government through the PSDP projects that we called for this. I think one of the other things is our insurance program that runs in hardly 3 provinces, more so in 2 provinces, does not have primary health care. So we just have secondary and tertiary care in our health insurance. I think it's right time. We need to have primary health care in our health insurance program. We need to have greater integration of primary health care like Brazil, strong interrelation, gatekeeping, referral pathways between primary care and referral system. And I think one of the things that I liked about Adelson's presentation was Familia Bosilia, if I'm pronouncing correctly. We also have one of the largest social security programs in Asia called the Benazir Income Support Program. I think we need to better promote CCTs, the conditional cash transfers through them. We have some minor cash transfers, conditional cash transfers for nutrition and education, but I think we should use that instrument much more aptly for health. And we should develop those cyclical typical mechanisms for reassuring, protecting health budgets, especially for primary healthcare, towards economic downturns. And I saw a Brazilian case, their health, because of the guarantees that they had, they were able to spend much better, and if not much better, but at least have the ceiling maintained. But lastly, I know you're short of time. I will end my saying, because we have all the ingredients. If I see, we have the Provincial Commission Award, we have the Social Security Program, we have everything. I remember this quote from Alice in Wonderland, where the Cheshire Cat asks, Alice was lost, and Cheshire Cat asks, where do you want to go? So Alice asks, oh, how should I, go through the way that I'm lost? So the Cheshire Cat asks, where do you want to go? And she said, I don't care. And he said, if you don't care, you don't know where you want to go. So for in our systems like Pakistan, if you do not know where you want to go and how you want to go, I am talking more about implementation, because one of the things that I have as an implementation practitioner I've seen is we have necessary ingredients, necessary policies, and necessary strategic plans. I think we are weak in implementation. So if you have to have the right direction, I think you have to have, from papers to actions. I think that's much needed. I'll stop here, and maybe there are more reflections.
Thanks, Shabana. No, excellent. And that's maybe my segue to some of the questions raised by the audience. Huh? So Adelson, it was super brilliant, and it's impressive. We are of course also impressed by the commitment of the authorities of Brazil to update and upgrade their policies to progress towards PHC. But yes, in terms of implementation, can you share a bit maybe of the challenges that you encountered from an implementation perspective?
Yeah, so a few comments on that, the implementation. We successfully managed to decentralize decisions and provision to municipalities. However, it's a very large and unequal country. So for a large city like Rio de Janeiro, where I am at now, it's easier to find good managers and people with skills to train, to build capacity. But in small cities, in remote areas, for example, that is quite difficult. In terms of implementation, they get incentives, they can create one new family health team, but to sustain that in the long term and to get health professionals in that family health team, working in a small area, for example, that is a big challenge. One point in the presentation was the More Doctor program. Many countries have that. Finding doctors to work in remote areas is a big challenge for every country, and even more for large countries like Brazil, like Canada, for example. But with that, it's difficult to reach small communities and to sustain in the long term, to make the model sustainable and more equitable, like we can find in large cities, for example. Another one is the amount of work and I think that happened in many countries, when the primary care system is getting more complex, more robust, more things are pulled to be dealt in primary care. So more procedures, more bureaucracy, and people trying to take the patients more to primary care. And that increased the amount of work they have, the workload and the burden the teams face every day. And that is a big challenge, to keep doctors and nurses working in primary care over time. And so I would say those are a few comments different from what Shabana and Jacqueline said, just to contribute. It's not easy to keep sustaining over time. Continuity of care is something that primary care should do, but we need to make sure that those health professionals will be keeping working in the same place.
Adelson, thanks. Well, it's related. There was this question from our colleague Eva Pascual, based in Guinea-Bissau. To what extent have you really progressed with equity in Brazil? So you showed a few studies showing how PHC made improvement in terms of outcome, but are there also some studies showing that you have reduced the inequality in health with this approach? Are you aware of anything?
inequalities in health regarding the regional inequalities we have?
At national level, so
Yeah.
you mentioned there is indeed a lot of regional inequality. So is this approach successful to reduce the regional inequalities in terms of health outcomes?
There's one very beautiful article from the same group of researchers that I presented in one slide about the Bolsa Familia program, the cash transfer program. In a previous article, they present one analysis showing that when you have the cash transfer program in place for the right people in the right time, and when that is combined with the family health strategy, that boosts the effect.
Okay.
So it's not only doctors and nurses treating ill people, and not only the multi-sector action, like providing food every day for the family, but the combination of those two strategies boost outcomes in infant mortality and neonatal mortality. That is a good article that I should keep in the presentation, but that addresses inequalities very well.
Okay, thanks, Adelson. And by the way, so several papers have been mentioned during this webinar. They may have been shared in the links in the chat. So check the chat if you want to access these papers. Adelson, you didn't. Well, we saw that there is a. When you presented health expenditure, we saw that there is some. There are some households adopting voluntary health insurance. There is also out-of-pocket payment. So I guess that there is a strong private sector in Brazil. So there was a question from one participant, I think it's Miriam, who was asking, are the private providers involved in PHC or not at all? So that's the first question. And then if you could reflect also, there was a question from Nicole, is family health team the only way to enter PHC? And imagine a household is not happy with its family health team. What they do, they can go to another family health team in another area. So you mentioned empanelment, but is it just you are assigned to a family health team, or can you choose to some extent? So two questions, but you guess they are connected.
Yeah, I'll start from the second one, and
Yes.
that is quite interesting. Shabana is now in Canada. And when I learn about the Canadian model, one principle is that the person should decide which one will be the health provider. So they can decide and they can move from one provider to another. And in Brazil, our model of care doesn't allow that. If I live in one block, I will have one family health team. And if you live in front of me, we're neighbors, but you live in front of me, you have another family health team. And I cannot see your doctor and you cannot see my doctor, even if I'm not happy. For me, my personal opinion, that's not a good solution. And this is one challenge for me in the model of care we have in Brazil. It's very crystallized in part of the success we have in the family health strategy. And many people believe that if we change this formula of the empanelment related to the catchment area, we will break the system and we will lose all the gains we had. I don't think so. I think that patients should decide which one will be the provider. And that maybe will help to increment and to change things in the direction of efficacy. The other question, Bruno, Brazil has an interesting story regarding the private sector. As Shabana said, we also have a private sector, very strong. 25% of the Brazilian population go to the private sector through private security or out of pocket. But primary care started to grow in the private sector just for the last 10 years. Before that, primary care was for the public sector, for in the communities, not for the rich. And many insurance companies started to implement primary care with the promise of saving money, bringing primary care and family doctors and skilled people. So in the private sector, this is the discussion today on how to make it more efficient and save money by implementing primary care. But this is a big challenge even for them. It's very, very, some companies manage to implement a little, but it's a very, very driven by specialist doctors, cardiologists, pneumologists, and they don't want to share the clients with the primary care and with the whole different organization. So in that term, many countries made the different pathway. Like family medicine, for example, started in the private sector, not in the public, but Brazil was in the other way around.
Okay. There were, Adelson, there were so quite a good number of questions on the gatekeeping function. So Shabana explained that it's not in place in Pakistan. But when we were preparing this webinar together, you mentioned also that there is a growing number of people going straight to emergency units in the hospitals for good or bad reason. So is gatekeeping working well? And can you reflect on that as well, please? It's a problem in many countries.
Yeah, yes, it is, and also no in some ways. Yes, because the rule is you should enter the health system through primary care. So you should go to your family health team and your primary care provider to present or to start seeking care. So that is the first contact. If you need any other type of treatment in secondary and tertiary care, the entrance door will be the family health team and primary care. But since 2011, a new policy for the creation of emergency rooms in the country took place. And the issue here is that we now have parallel systems. So the emergency room, they enroll, they cannot refer the patient to a secondary care, but sometimes they do. They go to one of those emergency clinics and they go to the secondary and tertiary care. So if we have parallel systems, then we lose efficiency and we invest more money to those two parallel systems and we lose efficiency. So the regulation also for the gatekeeping function, that is also another issue. If, for example, I refer a patient to the cardiologist and I can get denied that referral, they will say, oh, this patient should not go to the cardiologist. Okay, the line for the cardiologist will decrease. We will take this patient from the line. However, the issue for the patient will still persist. How can I manage that situation now? And that follow-up or the feedback doesn't happen. So that it's not used to improve the quality for the team in primary care. So in some ways, yes, it works, but it could work better if you use that information to improve the quality for the teams and make the information, the flow of information go from the first level to secondary and tertiary and back. And that will help to bring intelligence in a way to make it more efficient.
Thanks a lot, Adelson. That was very informative. Maybe a last question, but I would go maybe to Shabana or Jacqueline. Well, one participant raised the question, and how do we do that in fragile states? So indeed, we have been talking here about Brazil, which is middle income and with strong economic growth. And we understand already that things are more challenging in Kenya and Pakistan. I know that in both of your countries, there may be settings which are more challenging. So, Jacqueline, any reflection on the fragile state or fragile setting perspective?
Thank you, Bruno, for that question. So yes, indeed, the situation in Kenya is not homogeneous. There are some counties where we have insecurity issues, and definitely in those issues, access to primary healthcare or any healthcare services at all is definitely a challenge. But one of the strong points that would promote access to health service delivery would be strengthening the community health program, because these community health promoters are from within the communities where they they provide services within the communities from where they hail. So they would definitely, be able to provide to some level of access of service delivery, even within, insecure insecure situations, or even even during pandemic situations. They would definitely be a very strong pillar to support access to basic healthcare services in such delicate conditions.
Community health workers as a resilient health system. Thanks a lot, Jacqueline and Shabana.
Just quickly, Bruno, I think for fragile states, I think PHC makes more sense because it should be the backbone. So I think I forgot the point of political advocacy. I think that's more important. Health is a political subject. There is politicization of budget. So I think we should make a case, and primary healthcare definitely does not look fancy to any of the governments. So it's more about having a fancy tertiary care inaugurated. I think we should do a better job on presenting primary healthcare as the backbone, especially for fragile states where there's not a lot of funds. Secondly, I think because we don't have monies in fragile states, and even in countries like us in Pakistan, I think more about efficiency of spending. If you have $10, Bangladesh spends less than us in Pakistan, and they have better indicators. I also had a case. In fact, I raised a point, Kenya and Brazil almost spend similarly, but their outcomes are very different. So that's also a case in point on how do you get more health for the money you're spending rather than more monies and more health. So I think efficiency is an important angle for primary healthcare, and we should be deep diving. It's not an easy question, and there are no easy answers, but there could be done, on different ends. Efficiency, politicization, and emergency funds, maybe a guarantee of funds for health, because health is important, and in fragile countries and contexts, health is most vulnerable. So yeah.
Thanks a lot, and obrigado, Adelson. Thanks a lot, Shabana and Jacqueline, for this fascinating webinar. But the most difficult task is not with me, it is with Faraz, my colleague, who is the expert of how you play with the levers of PHC to progress on this agenda. So Faraz, what are your take-home messages of today?
Thank you, Bruno. Well, first checking, can you hear me?
Yes, we hear you well.
Great. So I don't think it's a difficult job. It's a very easy job with already such an enriched discussion and very esteemed panelists. So it's an easy job. What I'll try to do here is that I'll try to summarize my key takeaways in terms of some of the policy shifts which we are seeing in these countries. And then I'll share a few links. I already shared one, the recently released global report, because some of the points which are discussed, each one of them requires like the series of webinars, the governance arrangements, the financing arrangements we are talking about, and how we reorient our service delivery towards primary healthcare. So each one of them is an important bucket of questions. But something for a broader audience, I will say that if we look across these three countries, but also similar other low middle income countries who are reorienting their health systems towards primary health care with relatively better results and better, I should say, with more success in comparison with others. First clear shift we see here is that they have moved from short-term input-focused initiatives towards some long-term system-wide reforms. And that's something which we clearly see in Brazilian's experience. Like it's a reform spanning across at least, even if we take the start from 1998, and now you say it's 27 years, at least. And they have been iteratively improving, refining that. But what we see in many other countries is there is policy inconsistency, including my own country. Shabana can verify that in Pakistan. We often say we take one step forward and two steps back. And with every successive change of governments, there is launch of new programs and wrap up or rollover of the previous ones. But what you see, even if when you launch a program, which might not be perfect to start with, but if there is policy consistency, and there's a group of technocrats, bureaucrats, and politicians who commit to that, iteratively work on that, I think a time comes when the system starts giving results. So that's one key shift, which we see in countries which have led better reforms. Second is, I know it's a bigger debate that whether it came up in the questions here too, that whether we need decentralization for successful PHC-oriented reforms. Clearly, the evidence doesn't support that. But what we see here is that it's not only decentralized broader governance arrangements, but how you devolve authority, capacity, and accountability. That's more about it. Because if you want to deliver services closer to communities, your service delivery units, they need to be capacitated. They need to be given some power, authority, and then they need to be held accountable. So irrespective which political governance system you operate in, the key here is how do you transfer capacities? You give financial and governing authorities, but you hold them accountable. That's clearly a shift we see in countries which have led better reforms. Third, clearly we see from hospital-centering financing towards strategic resource allocation favoring primary care. Also moving from passive service models towards active community engagement in defining, delivering, informing services, but also a shift from physician-dominated care to multidisciplinary teams, from siloed services towards integrated models of care, from passive input-based provider payment arrangements to more strategic purchasing, capitation-based or blended provider payment arrangement systems. But also, though in this webinar we could not talk more, but I saw some questions, the role of private sector, how much it is unregulated and how much it is integrated with cross-sector stewardship by the state, where private sector joins the forces in delivering the broader public health goals. And there are two aspects which we don't have time to comment on. One is because it's an important topic about service delivery model. But before we talk about whether gatekeeping is a requisite or not, I think we need to understand that for any effective service delivery model, you need to have some essential ingredients. That whether first you have clarity on the services which are to be delivered through pooled public financing, that's the prerequisite, which are essential services, which a state considers as a responsibility, which are considered as a right. Health is a right, but within that, if those essential services which are delivered through pooled public financing. But then what is your service design? Because some of the elements which were discussed here, the service design could include, of course, an empanelment system, the system to promote first contact accessibility, the patient referral, counter referral, and emergency transfer systems, which all three colleagues talk about. Availability and enforcement of clinical guidelines, the existence of care pathways for key conditions. So not only planning and selection of services, service design, but how do you organize and management, the role of professional and leadership, appropriate management authority and scope, the supportive supervision systems, but also how do they connect with community linkages. So again, I will say it's not only gatekeeping, because in some countries, I understand, like I said, in Pakistan and Kenya, if historically over the decades, empanelment didn't exist, gatekeeping didn't exist. If you start enforcing gatekeeping from tomorrow, it will not be politically sellable. You first have to make your primary care ready for that. So the first contact availability of services, health workforce, the infrastructure and equipment. So the whole notion behind empanelment is fixing responsibility of a group of population for a health facility. So fixing that responsibility, understanding that, and delivering that responsibility. And as I said, then defining those care pathways, and then you can move towards what we with the gatekeeping. In fact, in recent WHO literature, we have not been talking a lot about gatekeeping. We are talking more about improving your service design, and so that automatically it gets streamlined. And my last comment here is, I think, with regards to better governance arrangements, which foster service integration. Again, it's a whole webinar series on service integration, how countries have done, what are still the lessons learned. But how do then, while integrating their services, they ensure services of high quality? But also, how do you strengthen your decision-making management units? May it be a district level, may it be a service level unit, or it be a provincial system. So these are some of my overarching reflections. I understand I have taken more than 5 minutes. Bruno, with this, I will end with last one statement that, because it's in the end, it's a health financing webinar, that how health financing enables PHC orientation. So Bruno had asked me that for us, from broader discussions and literature, what are those areas which we still need to talk a lot more about? And I will say, our financing discussion so far within the PHC world has focused a lot on integrated health services. We have worked less relatively on how our financing arrangements support multi-sectoral action policies and institutional and sustained community engagement and empowerment. So these are the two areas which I think the broader health financing community need to regularly think that they embrace the other two interrelated components of PHC approach. With this, I hand over back to Bruno and Isidore.
Thanks a lot, Faraz. No, that's a fascinating conclusion. I think it was really a wonderful webinar. It was really nice to bring this conversation so close, and that was really thanks to Brazil and Adelson. It's something we have been missing in the global health community. The Latin American countries, they are far away. They are not very much connected with the rest of the world. We miss you. So Adelson, we were very happy to have you with us. And I hope and I believe that everyone learned a lot today from this experience in Latin America. I will remember also this political commitment from a full population, a country really to make this kind of achievement. So I think that can be a source of inspiration for many of us. Okay, thanks a lot. This is also probably the last webinar of this series for this fiscal year. So we do that together with the World Bank. With that, I stop here. Thanks a lot for all the speakers. Thanks a lot also for this wonderful audience and your many questions. Thanks and see you soon. Bye.